What's up, everybody? Dr. Rossi, shrinksandSneakers.com. So I'm going to talk about a topic that is full of stigma, and anything to do with addiction medicine or addiction treatment generally has lots of stigma surrounding it. So I'm going to cover the medication buprenorphine or Suboxone, and I'm going to tell you all about this medication, all about how to use it, how it works, and why I think it's actually a really good thing and that more doctors should be prescribing this medication. So buprenorphine is a mu opioid receptor partial agonist. So this is very complicated stuff here. So it's going to bind to those mu opioid receptors that other drugs like heroin would also bind to, but it doesn't fully stimulate the receptor. It acts as a partial agonist. And we'll explain more about that in a little bit, why that's important. And it's most commonly prescribed as what I said before, as Suboxone, which is the combination of buprenorphine with naloxone. And I'll explain more about why that's important too. So the FDA approved this medication for the maintenance treatment of opioid dependence. And that's a good thing, right? Because we don't have a whole lot of treatments other than methadone. And the reason why methadone kind of has fallen out of favor is for several reasons. One is it's very stigmatizing to be on methadone and be at a methadone clinic. And two, you often have to show up on a daily basis to get your methadone medication. They don't give you a lot of take-homes. It's highly federally regulated, so it's not easy to get treatment with methadone. And it's not easy to be in treatment if you're being prescribed methadone. So let's talk about the mechanism of action here, because it's very important. I said already that this is a mu opioid receptor partial agonist. And I've talked about partial agonists before, and I had said that in certain contexts they can act as blockers, in other contexts they can act to stimulate receptors. So it will really depend on the physiological state of the patient who's taking the medication. So it binds, the first point to know about buprenorphine is it binds with very high affinity to the mu opioid receptor. And what is that going to achieve? Well, let's say I relapse and I go out and I inject some heroin and I'm on buprenorphine and I've been stabilized on buprenorphine, let's say. I inject the heroin, and what's going to happen is that because of the high affinity, the high binding affinity, basically, you can think of it like this. If I'm showing my hands, like this is your buprenorphine, this is the receptor, it binds really, really tightly. So when the heroin comes in and tries to displace that, tries to move that buprenorphine off of the receptor, it's not going to be able to do so because the affinity of the buprenorphine is much higher than the affinity of the heroin. So what's going to end up happening is you're going to block all those pleasurable or euphoric effects of the recreational drug, which can be beneficial, right? Because we're trying to work on that reward pathway, that dopamine pathway in the brain, and we want to interrupt that. We want to see like, well, if I inject heroin, I actually don't get any euphoria or any response from it. So what's the point of doing it? Now, I said it's a partial agonist. And I said that's important because let's look at it this way. If the person is in withdrawal and I give the person buprenorphine, it's going to stimulate the mu opioid receptors. So it's going to relieve that person's opioid withdrawal. So again, somebody's withdrawing, I give them buprenorphine, it stimulates the receptor and it's going to help that person to deal with the withdrawal syndrome. They should have no withdrawal symptoms, or at least that's the goal when someone's stabilized on this medication. Now, how about the other case? If you're in a case where you give this medication and the person is not in withdrawal, meaning they're actively using recreational opioids, and then you give this medication, let's say you don't know, or you assess them and you thought they were in withdrawal and they weren't. Whatever the case is, if you give this to someone who's not in withdrawal, then it's going to act as a blocker. So essentially, instead of stimulating the receptor and making the person feel better, you're going to precipitate their withdrawal. So that's the reason why it's important for the person to be in withdrawal before prescribing the medication. There's a couple other key points I want to just point out for you guys, and that is that buprenorphine is also an antagonist at the kappa opioid receptors. And you may be wondering why with the medication Suboxone specifically, where I said they combine buprenorphine with naloxone, why do they add that naloxone? So naloxone is added to buprenorphine, and if you think about it, theoretically, you would say, well, Dr. Rossi, wouldn't that just block the opioid receptor to prevent buprenorphine from working too? And it's like, yeah, theoretically, you're right. I mean, if you were to give like an intranasal version of Narcan or an injectable version of Narcan, that would happen. But the reason it doesn't happen is because the Suboxone comes in a sublingual form, meaning it goes under your tongue and you let it dissolve. It either comes as like a thin film that goes under your tongue or a tablet that goes under your tongue, and it will be dissolved. Now, when you take naloxone orally, PO, it doesn't have much bioavailability, meaning that when I take it, it really doesn't produce any biological effect, really. It doesn't get absorbed, it doesn't interfere with the treatment. There's no problem with the naloxone if you take it properly. Where this becomes an issue is if the person tries to, say, inject the Suboxone, then it's going to, there's much higher bioavailability, like I said, with injectable Narcan or naloxone, that it's going to immediately precipitate withdrawal. So if somebody were to inject it or try to use it in a manner other than as directed, the person would have a very rude awakening. So this is to prevent some of the abuse potential for the medication or some of the misuse potential for the medication. Now you're probably wondering about dosing. So let's talk a little bit about how you dose this medication. So I already said it's sublingual, and generally the doses are somewhere between 8 to 32 milligrams per day for most patients. So most patients will be able to take somewhere between 8 and 32 milligrams. My personal experience is that a lot of patients level out around 16 milligrams to 24 milligrams per day. There is an injectable form of buprenorphine that can be dosed as 100 to 300 milligrams every month. So this is a monthly injectable version of the medication. And there's also an implant. So the implant actually goes under the skin. It's a little bit of a, minor surgical procedure, I guess you could consider it. And you put 4 implants in. You put 4 implants in and they go under your arm here, like in this section over here. And you put these 4 implants in and they last for 6 months. The implants stay in for 6 months and then they're removed and new ones are inserted. This, honestly, is not my favorite way of doing it. I've never seen anybody on the implant. I have seen people on the injectable version of buprenorphine, but I'd say the most common remains the sublingual. And this one is not really very exciting in my opinion, even though it's kind of a cool concept. Suboxone comes in different forms. So I said there's a 2 milligram, and that comes with a half milligram of naloxone. So it's a 2 milligrams of buprenorphine, half milligram of naloxone. There's a 4 milligram tab and a 1 milligram. There's an 8 and 2 milligram. There's a 12 and 3, and there's a 16 and 4. Now, if we're talking about the implants are 26 millimeters in length and 2 to 5 millimeters in diameter, and they contained 74.2 milligrams of buprenorphine. So a 26 millimeter implant is placed in your arm in 4 different locations, and it provides 74.2 milligrams of bup for each one. The injection is 100 milligrams and 300 milligrams, and I'll talk more about how to use it in a second. So how do we use buprenorphine effectively? The first thing to note is that, like I said, patient must be in mild withdrawal state. So before you start this medication, the person's got to be in withdrawal. You're going to observe the patient for at least 2 hours after giving the first dose. And then a typical example would be something like this. So if I was in an outpatient clinic, I see the person for the first time, I do a COWS score on them. So that's clinical opioid withdrawal scale. It's called COWS. You can find it on MedCalc, or you can get a printed version of it. You do the COWS score, you calculate that the person's say at least 8 on the COWS score, somewhere in that range. And then you would give your first dose. And normally we usually start with a 4 milligram and 1 milligram tab or film. And we observe. We see how the patient does. Do they still have withdrawal syndrome after a half hour, an hour, 2 hours? We see where they're at. And we're going to observe them over that 2-hour period, and then we're going to say, okay, did the 4 milligram work, or do we have to give another 2 milligram or another 4 milligram? And you really do it based on your clinical assessment, but also based on your COWS score. So you're going to continue to assess the person and determine what dose they are. And that's the induction phase basically at that point. And that can take a little more time than just a single day. You may continue to adjust the dose over the next couple of weeks. The goal of this process is to find the lowest required dose to eliminate withdrawal and to prevent the use of illicit opioids. So the goal is to prevent the person from using illicit drugs and also to eliminate all withdrawal. Now, I said stabilization can actually take a while. It can take up to 2 months to complete, so you may continue to adjust and tweak doses up to 2 months. And the maintenance dose is generally somewhere, like I said, between 8 milligrams per day and 24 milligrams per day. During the stabilization period, The patient should be seen once per week minimum. A lot of times when I was seeing patients outpatient, I would prefer to see them daily for a while just to make sure they're in the program, they're getting counseling, and they're also okay on the medication. But you can see them as little as once per week during stabilization period. And then during the maintenance period, patients can be seen either biweekly or monthly. I think the more contact you have with your physician, the better. So I personally prefer things like bi-weekly, not monthly, but some patients are on a monthly. Okay, so tips for dosing. So either you as the prescriber or someone who's taking this medication, you want to remember, do not swallow the strip, right? When they give you that sublingual strip, stick it under your tongue, let it dissolve, or else it will decrease the bioavailability of the medication. So you want to place it under your tongue, let it dissolve completely. Do not chew it, do not crush it, do not move it around, just leave it there, let it dissolve. Only buprenorphine and naloxone should be used for unsupervised administration. So basically, if I'm going to give someone take-home medication, like I'm going to give them 5 days, I always prescribe the buprenorphine and naloxone combination. I never prescribe buprenorphine by itself. That's an important point to know. When switching between a sublingual tablet or film, the film actually has greater bioavailability, so it's important to monitor for over-medication, and obviously the other way around too. So switching between, so remember, sublingual tablet and film, the film has the greater bioavailability, so you may over-medicate the person if you're switching from tablet to sublingual film, and vice versa. So being mindful of that. The implant, let's focus on the implant for just a second. Like I said, I don't love this. I think it's kind of a silly idea, but it exists and I want to talk about it. So the person must first achieve sustained prolonged clinical stability on the sublingual formula. So first of all, the person has to already be stable before they can go to the implant. It's not like they can come to your office and you just do the implant right away and then you're good to go. Now, I said before, it's 4 implants. So every time you come in, every 6 months, you have to get 4 implants placed, which is a lot. And they're placed subdermally in the inner side of the upper arm, and they're placed there for 6 months and then removed at the end of the 6-month period, and new ones are placed. You need to be certified, so the center that does this, so I couldn't actually just do this if I wanted to. I'd have to be certified in the ProBuphine RMS, so they have an RMS associated with this, with the implants, and I have to also be trained by their staff to place the implants. So they have to show me how to make the incision, how to place the implants, how to sew it up, etc., etc. Patients must be on maintenance dose of 8 milligrams per day or less for 3 months. So the person can only be on a dose of 8 milligrams or less for 3 months. So it's kind of like, it's kind of useless, right? Because I said most people level out somewhere around 16 to 24 milligrams. So someone being on 8 milligrams a day is like not really that common. And so this implant to me is kind of useless. But anyway, you also need to examine the implant site 1 week after you place it, because you want to make sure there's no infection develops, there's no redness, swelling, etc., no allergic reaction, etc. So definitely 1 week after, check it out. If you're using the injectable form of buprenorphine, this is like other injectable medications, like I use paliperidone, I use Aristada, which is an Abilify formulation. These medications require a loading dose, so you actually have to do 2 initial loading doses of 300 milligram per month, followed by a 100 milligram monthly maintenance dose or 300 milligram monthly maintenance dose, depending on the patient's response. So what I would usually do if I'm doing the injectable form is I would do the 2 300 milligrams. So first month, 300 milligrams, second month, 300 milligrams. And then the third month, I would probably try the 100 milligram first and see how the person responds. And then if they don't respond well or need more medication or feel like it's wearing off at the end of the month, that's the most common thing that people complain about with injectables, is they feel like the injectable medication starts to wear off by the end of the month. So they may need 300 milligrams on the next dose. Now you administer this one subcutaneously. So this is actually a little different than what I said about paliperidone or Aristada. I said those are intramuscular injections. This is subcutaneous in the abdominal region, basically the same way it would be done for like diabetes medications or insulin. So it's not an IV or IM medication, it's a subcutaneous medication. And at least 26 days should elapse between dosing. So you should not give this medication any earlier than 26 days after the last injection. Tests to order are things like LFTs at baseline. So you want to get the person's LFTs and be sure that they don't have any severe liver issues, because you do have to adjust your dose based on that. I'm going to kind of finish up the video here with the last couple of pieces. So you might be wondering, Dr. Rossi, is this habit forming? Aren't we just replacing one recreational drug for another recreational drug here? And yes and no. I mean, I guess the way I look at it is I treat it like a harm reduction model. And when I say it's a harm reduction model, what I mean by that is that I'd rather the patient be taking buprenorphine than using injectable heroin that could be laced with fentanyl, that could be laced with God knows what, that could put them at risk for endocarditis and put them at risk for HIV and hepatitis C, when they could be on a medication that's safe, effective, and clinically monitored by me, a physician, right? I'd rather that. So that doesn't mean it's not a Schedule III drug, because buprenorphine is a Schedule III drug, and there can be physical dependence on this medication as well. So you have to be mindful. If you want to stop this medication, my recommendation is to not taper it yourself or try yourself, because withdrawal is definitely possible. You should talk to your physician and get it tapered properly by a medical professional. That's always my advice to you guys. Side effects, common side effects, things like headache, constipation, and nausea. Obviously, anyone who's ever used opioids before for a consistent amount of time, or who treats people with opioid use disorder, knows that constipation can be a serious problem, and you do need to be mindful of it. Should someone develop constipation while on this medication, you need to treat it. So headache, constipation, nausea. Tooth decay is a recent one. So unfortunately, they just recently found out that this sublingual form of buprenorphine actually does cause some tooth decay and some dental problems. So you got to be mindful of that. The way you avoid that is obviously good dental hygiene, seeing your dentist at least every 6 months. Orthostatic hypotension is possible. If you're using the implant, obviously you can get infection and pain at the site of the implant. Rare but serious complication would be respiratory depression. So always avoid prescribing this medication with benzodiazepines. I never like any of my patients in treatment for opioid use disorder to be on benzodiazepines for the risk of respiratory depression. In rare cases, there can be liver complications, and sedation is also possible. So to tie this all up, it's metabolized by cytochrome P453A4. The elimination half-life is 24 to 42 hours, so you can see based on the half-life that it is possible to dose this medication once daily, right? It's got at least a 24-hour half-life. The implant time to steady state takes 4 weeks. So for the implant, it takes 4 weeks to reach steady state. And for the injection, it takes 4 to 6 months for plasma levels to achieve steady state, and it may be detectable in your blood or plasma for up to 12 months after discontinuation. So you should know that in case somebody is being tested or something like that. It's important. So to wrap it all up, in general, buprenorphine is less stigmatizing than things like methadone, and the adherence to buprenorphine is generally better than methadone. It's relatively convenient, right? Meaning I can do this in my office. There's flexible dosing and ease of discontinuation. It's much more accessible, I think, for the patient to get this type of treatment rather than methadone. And my final point here is that it saves lives, right? I'd rather have you on Suboxone than have you on opioids from the street, because I know what I'm giving you, and I know you're going to be at less risk for medical complications or things like overdose if you get laced heroin with something like fentanyl. So I'm going to hold the video there. If you guys have questions or comments, please drop them below. And please like and subscribe to the channel. It helps me to keep making this content.